It's my pleasure now to present our rather provocative data because we have heard many beautiful presentations about the mechanisms, about the examinations or testing in the tissues, in the cells, in experimental animals, but we didn't hear anything about the human beings as far as I know. So that's why I would like to move your attention to this part. To my knowledge, there are really no human studies available to evaluate the effect of nanoparticles in the production or use of those products. And for an occupational physician, as I am, it's quite an important question what to examine in the workers who are exposed to nanoparticles during their everyday jobs. What non-invasive methods could be used for the preventive examinations. The mechanism of oxidative stress, as we have heard in the previous presentation, the effects can be studied by several methods, and usually the markers of protein oxidation, DNA oxidation, and lipid oxidation are used. Most frequently, we can see those lipid oxidation either in the direct way, as from the acids of the cell membranes. As an example is the arachidonic acid. With the direct oxidation, 8-isoprostane is formed. That is a marker of oxidative stress. And we can see also other lipids oxidized into aldehydes, either the more simple or more complicated. Then even the enzymatic oxidation of the lipid from the membranes can occur through the enzyme lipoxyoxygenase, and these are usually also considered markers of inflammation. Leukotrienes, either LTB4 as a marker of inflammation in the airways, in the chronic obstructive pulmonary disease, for example, or sustaining leukotrienes in allergic lung disorders such as asthma. So, about our study. We focused on titanium dioxide production and the workers exposed in one big plant to produce pigment. Titanium dioxide is famous for its extremely whiteness of this powder and opacity that it gives to the products used in the industry for paints, coatings, papers, etc., but also for foods, including the yogurts or pharmaceuticals, pills and tablets, but also toothpaste and sunscreens. The workers were examined both pre-shift and post-shift, and we had a control group, and it all happened in February 1 year ago. It's interesting about titanium dioxide that it causes some before unexpected effect. After the irradiation by UV light, it mediates a chemical reaction, production of hydrogen and oxygen from water. And this effect is also used for degradation of the pollutants in water and hydroxyl radicals, so agents causing oxidative stress were also proven in these processes. So our workers were 20 males, 34 years on average, rather young, and maybe surprisingly, even for us, there were more than half of the smokers. Their exposure was not very long, it was about 9 years, and the controls were also males, and their age was about the same, and also the smoking habit was about the same. What methods we used? In addition to the normal examination that we perform during preventive examinations such as lung functions, history, physical examination, and so on. We focus on exhale breath condensate, fractioned exhaled nitric oxide, analysis of urine, including titanium in urine and in the exhale breath condensate, and a detailed measurement of the aerosol exposure was performed in the workplace. We have heard something about exhale breath condensate in the previous speech, but to say so that you can imagine what it really, excuse me, what it really looks like. So it's a non-invasive examination where the person sits for 10 or 15 minutes and breathes tidily, peacefully into a cooling device where the vapors from the breath are cooled to minus 10 degrees of centigrade, and the nose is clipped to exclude upper airways contamination. Then the fluid cooled is frozen to minus 80 degrees of centigrade and analyzed. Of course, exhale breath condensate contains the biggest percentage of water, but also the non-soluble particles, and the origin is supposed to be from respiratory bronchioles that contract during expiration, and small droplets are formed. And also water-soluble particles, of course, are included in the exhale breath condensate. The method was described by this European Respiratory Society monograph. The advantages, as I mentioned, non-invasive, can be repeated many times a day in the small children, in elderly people, in ill patients. And there is no influence of smoking, no interference with the smoking. Disadvantage is, to be very exact, it's a high price of the analysis, because really trace amounts of the agents are analyzed. It is not considered as a standard method. It's a research method till now. There are some questions about the concentrations evaluation, because there is nothing like creatinine in urine to compare with some such agent. So to solve the question, several ways were suggested, and most recently a dilution indicator conductivity was suggested, and it was also measured in our workers and controls by these described methods. So many markers have been analyzed in the exhale breath condensate. We have heard about them in the previous speech a bit, and there are markers of oxidation of the lipids, of the oxidation of nucleic acids, of proteins, and also markers of inflammation, leukotrienes, and also exhaled nitrogen oxide with the machine I will describe just now. So this, unlike the exhale breath condensate, is already used in the clinical practice, especially for the asthma patients, and it is pointing to the inflammation in the respiratory system. It's related with the more acidic pH in asthmatic patients, especially with those who have more eosinophils in the airways. It's easy, simple, non-invasive. It's a bit even funny when the workers had to make the dolphin flow through those circles. Nobody succeeded for the first time, so twice or three times everyone had to test. So it was a bit really fun for them. There is quite a big disadvantage because it's lowered in the smokers. It's not exactly explained why, but it's probably due to damage of the epithelium in the airways where the NO is formed. So this is a disadvantage. So we try to overcome this disadvantage with other methods. Then the urine analysis was performed of the same markers, and the same markers, our chemists are able to analyze them in the blood also, but this time we have chosen non-invasive examinations. The exposure measurements at the workplace. So the particle number size distributions were monitored, and the size range possible to measure was from 50 nanometers higher, and the result is that about or even more than 20% of the particles measured were smaller than 100 nanometers, so they were in the nano size. And 4 shifts of workers were examined, and during 4 shifts the measurements were carried out. Production occurs in the basement and in the first floor of the plant. So here you can see the maps of the total concentration of aerosol particles, and here at the left side is the number concentration at the basement, and the number of particles were from 10,000 to 200,000 particles per cubic centimeter, and the mass concentrations are seen at the other picture, and the mass concentration was in the range from 0.1 to 30 milligrams per cubic meter. Here are the pictures from the first floor, where the concentrations were a bit higher, the number concentration especially. And then titanium was measured in the biological samples, both in the exhaled breath condensate and in the urine. The results. First results were already presented at the conference NanoCon in Brno in October this year. And at this picture, you can see the oxidation products of lipids. And the first bar is always the darker, is the pre-shift concentration in the workers. The second is the post-shift concentration, and the blue one is the control. So you can see that not only the lipid markers, but also the nucleic acid markers were significantly elevated comparing to the controls, and the same was the case for C6 to C12 oxidation products. Here are the results of proteins change, also significantly elevated in the both pre-shift and post-shift samples of the workers, and also all these markers of inflammation, leukotrienes, were elevated, excepting LTD pre-shift in the workers. And the last columns are phenol, exhaled nitric oxide, that I will comment now. They were also elevated in the workers. Here are the numbers, pre-shift and post-shift. These were not significantly different, but they were higher than the controls. But we can see here the effect of smoking in the workers, and the number was lower in the smokers, as is known, as I mentioned, than in the no-smokers, and here the number was the highest. So this level already points to the inflammation in the airways, and if the people would be asthmatics, then treatment with corticosteroids would be considered. As to the evaluation of the concentration of the exhaled breath condensate, conductivity, as I mentioned, the method was measured, and no difference was seen between pre-shift, post-shift, and control subjects. But the pH of the exhaled breath condensate was more acidic in the workers in every time. Here are the results of titanium in the urine. They are not shown on the graph because they were not elevated neither in the workers and the controls, but only titanium in the accelerated condensate was measured. The blue columns are again the workers, pre-shift, post-shift, and the yellow ones are the controls. Just one control had a very mildly elevated level of titanium in the urine, at the same level as the 4 workers from the research plant, where the exposure was many times lower than in the industrial plant. There were several correlations of titanium in the experimental breath condensate with isoprostane or in hydroxymethyl uracil and many other markers that I don't show here. The workers from this research plant had levels somewhere here, but they were omitted because it's much lower than the other part of the subject. As to the oxidative stress markers in the urine, they were not elevated in so frequently as in the exacerbated condensate, so just some markers, but they included both the lipid markers, as you can see here, and also the protein oxidation markers, and the previous, the highest were also nucleic acid markers. So conclusions. As you could see in the workers, titanium in exacerbated condensate was significantly elevated, and all markers except pre-shift LTD4 was significantly elevated compared to the controls. Also, FeNO, an independent method, has shown there is something happening in the airways, some inflammation. And titanium in the urine was low in the workers. In the urine, nevertheless, several markers were also elevated, both pre-shift and post-shift. So what do the results mean? I must say that it's really a pilot study. The numbers of the workers and controls were quite low. What was surprising for us that the workers were so young that they don't stay a long time in this workplace. I can understand it's not very pleasant. It's very dusty and you feel the white pigment really everywhere. There was no further increase in the markers pre-shift compared to post-shift compared to pre-shift. Why? It may point to a chronic effect that not just the short exposure may show something, but maybe also it may be related to the photocatalytic reaction, because the workers were closed in the building, in the rooms. It did not go out for the sun. Day shifts, night shift, it was the same. We don't know if it's the effect of nanosite particles or more the chemistry. So what next? One further study is going on, atomic force microscopy, to analyze the size and morphology of particles of the samples already collected, and also the Raman microspectrometry. We have few results already with Achanas and rutil and soot, because both forms of titanium dioxide were present in the plant. And we spoke already with the plant to continue to examine not only the same workers with some time interval, but also more workers of the production and the office workers. If agreed, it's with red letters, because this is a big question. I think more studies are really needed, and such methods I suggest for use, because they could be non-invasively performed. And of course, prevention is more important than compensation. So with this, I would like to thank you for your attention, and also I thank all our colleagues for the work done. Thank you.
Thank you, Professor Peklova, for these interesting findings. Have shared them with us. A couple of questions.
Takuichi Hara, Nagoya University, Japan. Your study is very interesting for me. And you compare the shift and post-shift. And probably you compare using the corresponding t-test? Corresponding t-test. Within same individual, you compare.
Yes.
Okay. It's a very good to remove any individual variation. But I am interested in the relation with individual exposure level. Did you evaluate the individual exposure level?
Unfortunately, this was not possible. It was because the workers were from 4 parts of the plant. There was micronization and further, not with exactly the same level, but the workers did not spend the whole time in the production. They had their offices. They did not really go across the plant all the time. They were sitting at the computers watching the process, but twice an hour going out. So for this, a personal sampling would be the best, but I think it's not available yet.
Okay, and another question, a technical question. For the condensation, breath condensation, did they wash the mouth before breathe?
They were usually drinking before this, because if you ever tried this examination, you have to sit for 10 to 15 minutes without more drinking, and they drank before, all of them. Yeah.
Okay, thank you very much.
Any other questions?
Thank you for the presentation. Jacques Bouillard, Igneris, France. The exhale medium, you measure acidic pH. What does it reveal?
It's quite common in the examination of patients with asthma or with lung disorders, COPD, for example, and it's considered the most simple marker in exhaled breath condensate. So some starting inflammation.
Dr. Rediker, Michael?
I would be careful with interpreting it this way, unless you can show dose response with your pH, because we showed already a couple of years ago that slight work already clearly changes the pH. So it doesn't have to be the inflammation.
Yes, I agree. All right. It's much more complex, of course.
One short question.
Hi, I was just trying to make sure I understood correctly that the concentrations that were measured were up to 30 milligrams per meter cubed. And I guess my understanding is the occupational exposure limit is much lower than that. So were the workers wearing some type of protective equipment when they were in this exposed environment, or what was the situation going on? Could you give more details?
Mm-hmm. Yes, the workers had preventive protection available. They had to take it every time they went to the workshop. Most of them did, but of course nobody controls them, and maybe it's not related exactly to the concentration. I cannot tell, because really after just crossing the workshop several times, we felt the dust everywhere, and depending, maybe the concentration in gravity is not the crucial one for the evaluation, for the effect.
Okay, thank you very much, Dr. Peklova. And the next speaker is